Bye.
Welcome, everybody, to Knock Knock Eye with me, your host, Dr. Glockenflecken. This is, of course, your one-stop shop for all things eyeball related. I do have a couple of eyeball topics for you today. But first, we got some news coming out of the Olympics that we need to address. This is shocking to me and very surprising that this is the second straight Olympics where that we have had some drama related to penises. So penis, the multiple of penis. Maybe it's just penis. Multiple penises. I think penises is right. Maybe we can have a urologist weigh in. Anyway, if you recall, the Summer Olympics 2 years ago, we had a French pole vaulter that unfortunately was unable to clear the bar because of his enormous penis. Obstructed the bar, and it was his penis that knocked it off, and he wasn't able to continue on in the competition. Very unfortunate for that person. We all got a lot of content out of it. It was great. And you would think, well, that's like a once in a lifetime, like type of event. Like, how often are you able to like talk about, the effect that a penis might have on the outcome of the Olympics? Well, fast forward 2 years later, Winter Olympics in Italy. And I regret to inform you all that the ski jumpers are up to some shenanigans. So it turns out that they're gaining a competitive advantage. Not they, like some of them, right? Not all of them, but some of them are gaining a competitive advantage by injecting their penis with hyaluronic acid filler, basically. So, when you have like, when celebrities or anybody gets lip filler, it's hyaluronic acid that they're injecting, like a glycosaminoglycan, basically. It's just these like molecules that are dense and absorb water and things and just plump up your tissue. Well, they're doing it for the penis. And the reason is not to like make themselves look bigger down there. That's not the point. The point is, if you have a large enough genitals, then you qualify for a larger leotard, a larger outfit, the spandex. You can get more spandex, and there have been studies that have looked at this. They have equations regarding like drag as you're flying through the air, kind of like a flying squirrel. That's what these guys look like. They look like flying squirrels soaring through the air. And part of the evaluation of ski jumping is how far you go, obviously. And so if you can increase the amount of lift that you have as you go through the air, you'll just go farther and you'll get a higher score, right? Well, I guess people have worked this out. People that are very smart at physics, I guess, have figured out that if you have like a larger surface area to your body, or at least to the clothing that you're wearing, then you'll go farther. Sure, I just have to trust them on this one. I'm not that good at math, and so one way to do that is to just get a larger outfit with more surface area to it as you fly through the air. And so, of course, what's the best way to do that? Inject the penis. Get yourself a big old penis. And you get a bigger uniform, increase surface area, and you go farther and you win Olympic gold. How far would you go? How far would you go for Olympic glory? Are you willing to take that next step? Apparently, I don't know that, like, I think the World Anti-Doping Agency is looking into this. I can't imagine they had guidelines about penis injections. I'm glad they're looking into it. They probably, I don't know what they can do. Can they do anything at this point if it's not like explicitly stated? These are acceptable and unacceptable things that you can inject into your genitals. If you haven't spelled it out, then how can you get mad at, how can you blame these guys? I mean, come on, this is the pinnacle of their sport. How often do any of us ever talk about ski jumping? Like it's just it's on primetime TV now. So hey, I I'd like to say that there was no situation where I would inject my penis with penis filler, but I am not trying to win Olympic gold in a sport. Um so man, I mean you got to find your competitive edge like any way you can. If that means injecting your penis, now what's going to happen? What's going to happen to these penises with all this filler? Well, we know what happens with the face. So we know that, whenever you get filler anywhere in your face, over time, like that filler, it doesn't go anywhere. Like it doesn't, we for a long time, we thought it just degraded. Like eventually it went away and you would lose the effect of it. Clearly that's not happening, especially if you've seen some of the celebrities that have it doesn't age well. And a lot of, especially if you get a lot of that filler, it doesn't age well because what that filler does, what those, what the hyaluronic acid does, is it expands. And so that's what you see when you're like, you look at somebody like that looks a little unusual. It's because maybe it looked okay at first, but the filler expanded beyond where that person wanted that filler to be, localized in a particular part of the body. Instead of staying in the lips, all right, it's expanding into the face. So their face looks a little bit bigger, looks a little bit wider, looks a little bit more unnatural because that filler is expanding. You don't want that. Now, I'm not an aesthetic type of doctor. I don't do a lot of oculoplastics, certainly not cosmetic oculoplastics. And so I don't know, maybe there's a next generation of filler that's going to fix all this and people will look more natural for a long period of time. But for now, you're putting yourself at risk, especially when you're young, when you're in your like 20s and 30s, and you're going to have to live with this filler for 20 plus years. God knows what you're going to look like 20 years later after getting all of this. So please be careful with this stuff. And honestly, don't do it. I'd rather, I'm not going to, you won't see me with filler in my face. But again, it's not like I'm not the type of person that like the companies market to and the estheticians market to and the dermatology clinics and all the cosmetic folks. So, I'm not going to begrudge anybody who makes the decision to get filler. It's your body. You can do what you want with it. But I think just like a lot of things in medicine, we end up knowing things that we didn't know at first. Like long-term outcomes reveal unintended adverse effects of things like especially cosmetics. Where there's a lot of money involved. And so just be careful with it. And so now I wonder, okay, well, what's going to happen with the penis? The filler treated penis, hyaluronic acid. I guess it could do the same thing. Migrate. Maybe you're going to get a bigger penis, a bigger scrotum. Maybe going to, maybe you're going to end up with a very oddly shaped penis. I don't know. I guess we'll find out. Actually, maybe not. I don't think the people are going to say much. And maybe actually, as the filler expands and moves around, maybe that actually increases the surface area. So maybe like 10 years from now, we're going to have people that are like flying down that mountain further and further because their genitals have expanded so much. It's literally like they have a web, like they are an actual flying squirrel, and it's just it's so deformed, but it creates like this perfect parachute that allows them to just shatter world records. Maybe, who knows. Someone's gonna find this out. I need a deep dive. I need an investigative. There's got to be a documentary about this someday. Just like there's going to be a documentary about the guy whose penis caused him to lose the pole vaulting event. There needs to be a documentary about the people doping up their dicks. That's please. Let's hear it. Let's see it. Okay, or at least hear about it. I don't know if I want to see it. All right, so I promised you I have some eyeball topics. So one patient I saw in clinic recently, I'll tell you about. And another one I saw a while long. I was going through my archives, thinking through all the interesting patients I've seen over the years. And I do have like a log of patients that at the office of kind of interesting things patients, diseases I could talk about on the podcast or give during if I'm going to give a presentation somewhere, I can talk about interesting cases. So the first one, a patient recently actually showed up in the emergency department. Actually, both these patients started in the emergency department. And so I get a call. This happened during business hours. Thank goodness, as an ophthalmologist, I'm much more adept at thinking and working when it's still daytime. So call comes in from emergency room. I'm in clinic. And the doc on the phone, which I always encourage this, please, like, call your local eye doctor. Like, if you're especially during the day, give us a call. Like, talk to us. Like, it's fine. Like, we see a bunch of patients. It's an eye problem. It's not going to take that much time for us. So if you have the time as an emergency physician, like, and you're in a hospital and 3 blocks down the road, there's an ophthalmologist, give them a call. If you're don't know what to do about somebody, if you have a question, you don't know how to work someone up. And so that's what happened with this case. So this was about a 60-year-old patient who had sudden vision loss. And so I've told you guys before, sudden vision loss, you differentiate it with like sudden painful vision loss, like severe vision loss. That's typically a PANTS patient. So we're talking like it could be like obviously trauma, angle closure glaucoma, chemical burns, other types of trauma. Generally it's something like really bad if someone is in a lot of pain and they've lost a lot of vision. Painless vision loss could be a PANTS patient. Often it's not. All right. So pain is a big differentiator, but it's certainly if anybody has a sudden massive amount of vision loss, I'm paying attention for sure. And so that's what this patient came in with out of one eye. And the patient had noticed that suddenly they lost half of their vision. So it wasn't all the vision. That's an important differentiator. It wasn't all the vision. It was just the top half of their vision. Also had described floaters. Okay, interesting. So I'm thinking, what's at the top of my differential? Just hearing this. Within 30 seconds, I've been given this report. So what am I thinking? Well, obviously, I got to have a retinal detachment on the list. So you have a visual field cut. So half the vision's missing, and kind of a vague history of there were floaters. All right, no reported flashes of light, but certainly floaters. And so I'm thinking, okay, it could be a retinal detachment, but also a sudden visual field cut could be something like giant cell arteritis. It's possible, like an amaurosis type episode. It could be a clot. It could be an artery occlusion. So somewhere in the patient's body, by the way, this patient had diabetes. So they had vascular disease. So it could be something wrong with the blood vessels. You develop a little embolus, goes up to the eye. Bad luck. I mean, I guess any place an embolus goes is bad, but went to the eye, obstructed a part of the retinal vasculature, and then took out the vision. And so that's also high on the differential here. So they asked, they was like, "Oh, what do you think? What do you think we should do, doctor?" And I was like, "Well," I told him this, like it could be this or that. He's like, "Well, I did an ultrasound, everything looked okay there." That's fine. That doesn't really change kind of my feelings, but they're pretty good at ultrasound. Ultrasound is pretty effective these days at being able to see a retinal detachment. And the fact that it was half the vision, I say it didn't affect my decision making, but it's actually helpful information to know, because if a retinal detachment was large enough to affect half of a patient's vision, you're going to see it on ultrasound. All right. It's not just like you're looking for a tiny little tear and a small detachment. That's a big detachment. All right. Most now in 2026, most of the emergency physicians out there are adept enough at ocular ultrasound that they can see a detachment that large. They know how to diagnose that. So that probably knocked that down a little bit. Now I'm thinking, okay, maybe it is. Maybe this guy with a vascular history, sudden vision loss that's painless. Yeah, this could be a clot. And vision was poor. And so I was like, well, it's reasonable to go ahead and consider this a stroke, and you could do a stroke workup. And he's like, oh, I already did that. So that took that was great. That was like, okay, well, we don't have to go back and forth about this. Do I need to see the patient first before we do the imaging? It's already been done. So there was a CTA that was already done. And it looked clear. It looked clean. So I was like, okay, all right, well, you've done all the stroke workup, the labs, everything is done. I was like, that all looks good. You just discharge the patient. If they're safe to discharge, send them to me. I'll take a look. So that's what happened. Patient came over to my clinic right that day. It was like 3:00 in the afternoon. And I took a look, and sure enough, there was half of the retina. There was retinal whitening, and clearly a clot. I could see it. And now we don't know exactly where, but this is a stroke. And so the patient's getting set up with neurology and treatment for that. And we don't routinely do TPA for something like this because, well, first of all, this patient had vision loss for hours. So there's certainly not within any kind of time frame for the clot busting medication. But this was a branch, what we call a branch retinal artery occlusion. So it wasn't the central retinal artery, because that would affect almost all of the retina, at least the most important part of the retina. It was a branch retinal artery, so a smaller tributary off of the central retinal artery. So that's the reason that was only a portion of the retina was affected. Now, this was a difficult conversation with this patient. Actually, you know what? Let's take a break, and I'll talk about how that went with the patient.
Hey, Will.
Yeah.
It's February. It's the month of love.
It sure is.
Do you know what I love?
Me?
Well, yes. But do you know what else?
I don't know what.
I love eyelid mites now.
You?
Yep.
Eyeballs too, right? Not just the mites?
No, just the eyelid mites. Yeah.
Oh, okay, well, that's a start.
Mm-hmm. But I was just thinking that since they're so common, 1 in 12 adults has an overgrowth of eyelid mites, so I should be more accepting.
That makes sense. It's very normal for Demodex mites to be in and around your eyelids, too.
Yes. And I know that if they do happen to overpopulate and cause Demodex blepharitis, there's a prescription eye drop treatment, so no need to stress.
So relax. See, if you ever have itchy, irritated eyelids, just go see your eye doctor. They can examine your eyelids, check for crusties, what we call collarettes. Those are the things that mites leave behind. To learn more about eyelid mites and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. All right, when you have a clot like this, an artery occlusion that causes basically the death of your retina, parts of your retina, this can be a really challenging conversation to have with a patient, because the first question is, when's it going to get better? Is my vision going to come back? And what I tell people with this is that no, the vision will never be what it was. You have permanently lost vision from this. It's very important to just say it right. Just tell them you have permanently lost vision. Now, I then tell them, especially because I usually see these in the acute phase, right? Because the patient's coming in, they're concerned, They're coming in from emergency room, or they just walk in or call us, right, when it happens. And so I'll tell them, we don't know what your final vision is going to be from this, because there's a lot of edema, similar to when you have a stroke and there's the penumbra. We'll talk about the penumbra. That's the retina. That's the brain tissue that's still viable, that could still come back if you could just like control the inflammation and make sure that everything's reperfused and everything. And we don't call it the penumbra and the retina, but it's kind of the idea, is that as the initial swelling in the retina eventually goes down, and it does, because the retina reperfuses after that initial blockage, and there's collateral, fill in as well, that swelling can come down, and they can get a little bit of vision back. Now, it's not going to be a lot. So I'm talking about all of this. I try to keep it as simple, as short, and just because it's hard to take this stuff in whenever you're delivering bad news, when you're receiving bad news, it's hard to process all of this. This is something I've certainly learned from my wife, whenever she was hearing all the bad news about my cardiac arrest and the cancer diagnoses and everything I've put her through. And so, I take it slow, in plain language, explain vision will not be the same. You have lost vision. We just don't know how much. And so I'm going to be seeing you back, in a couple weeks. We'll have a better idea of where you're going to end up with your vision, but it can take up to 3 months for us to know what your new baseline is. That's basically, what I tell them, and reassure them, like fortunately we have 2 eyes, and your other eye is healthy. It's great. Extraordinarily rare for something like this to happen in the other eye as well, because this alone is a very rare event. And so that tends to help people, feel a little bit better. But so it was a tough conversation, but patient's doing okay. I do think some of the central acuity for this patient is probably going to come back at least a little bit. Fortunately, it was the branch, so it wasn't all the vision, and it was the superior vision as well. So if you're going to lose half of your visual field, you want it to be the top half. Because if you think about how we use our vision, a lot of it's kind of straight ahead and down. Reading a book, your lower peripheral vision, navigating your world, walking around, being able to identify obstacles without looking directly at them. We don't often use our superior peripheral vision. All right. Like, maybe like you're sitting at a stoplight and it turns green, right? You're maybe not looking at it, but you can recognize that it turned green. Or maybe you should be looking at the stoplights. So anyway, your inferior lower peripheral vision is much more useful to you. So if you're going to lose half, the top half's the one to lose. Fortunately, that was the case with this patient. And so, I think he'll do okay. And just like with anything, any difficult diagnosis, any difficult thing that your patients are going through, keep seeing them. Just be there. Even if you don't have a lot of medicine to offer, which in this case we don't, right? This is kind of the diagnosis you make, and there's not a lot you can do. But you still see them. You're still there. You're still answering questions, because there's going to be a lot of questions that they're going to come up with as soon as they leave the office, and then they come back, or you give them a call. So the point is, you're still there. That's part of being a doctor. That's an important part. Okay, so that was my branch retinal artery occlusion patient. That was an interesting afternoon. Okay, and so another patient that I'll tell you guys about is, let's see. Okay, so this was about a 70-year-old patient who came in to the emergency room with 2 weeks of progressive vision loss in the left eye. So as opposed to a branch retinal artery occlusion, which someone turned off the lights in the last patient, right? It was real quick. It happened over maybe a minute max. This is 2 weeks. It's been gradually getting worse. Patient reports that it's like looking through a fog in that eye. The other eye, totally fine. Totally fine. In addition to the ocular symptoms, this patient was also came into the emergency department for lesser so. Like this was not as big of a concern for this patient as the vision was, but he had this new skin rash on his palms and on his feet and on his genitals. That I think I would be probably a little bit more concerned about that, but that's me. Everyone's different. A rash on the palms, the feet, and the genitals. The rash is characterized as rough. The color of it was like whitish brown, what we call nummular in appearance. So it kind of had like rounded edges, kind of like a fistful of coins, like you traced a coin kind of thing. And it was a little bit tender, but it wasn't itchy. All right, itchy, you think like allergy kind of thing, or like certain infections. I don't want to venture too far outside my wheelhouse of ophthalmology and get into the world of dermatology. But anyway, so non-pruritic, basically. So non-itchy. No fever, no weight loss, shortness of breath, chest pain, none of that. No other neurologic symptoms like headache, weakness, ataxia. The only neurologic symptom, vision loss. All right. So on exam, you saw, obviously the rash is there. I was able to see the patient's rash. They uploaded. This is what's great about the electronic medical record now. Like I can get a patient like this on the phone, and I can log into Epic and I can see the pictures. It's great. I can't imagine. Like we make fun of electronic health records, but my God, like it really is like there's like something like this is such a step forward, and being able to like see this from like 40 miles away from my home. Anyway, the right eye was 20/20, left eye, count fingers, full motility, eyes moving okay, eye pressure's fine. The pupils, though, showed that the left eye had a severe RAPD. So that indicates that either the optic nerve is dysfunctional or a large portion of the retina is dysfunctional, or both. The front of the eye, slit lamp exam, looked fine. All right. So this patient ended up coming into the clinic. And the back of the eye showed, the optic nerve overall looked okay. There was a little part of the optic nerve that maybe the margin of it was a little bit soft, which could be a little bit of mild edema of the optic nerve. But what was very obvious was you had these big placoid areas of the retina that had hemorrhages and that were white, kind of like the whiteness you see in a branch retinal artery occlusion or a central retinal artery occlusion. The retina kind of looks white, but interestingly, it didn't so much look like swollen. It was just had this instead of like a nice orange reddish appearance, just had a white appearance, but didn't quite look like a swelling. And you can see that when you're doing your like ophthalmoscopy, because you do have a little bit of depth in your view. And so you can see if the retina is really swollen or if it's flat. And so with the retina findings and the rash on the hands and feet, this is actually a fairly easy diagnosis to make. This was, if you guessed it, congratulations, syphilis. So the patient had serologies, and this was a diagnosis that was actually made in the emergency department. So they did a great job with it. They knew it right away. I think it was mostly the rash on the hands, feet, and oh, by the way, the genitals that kind of tipped him off. So RPR, rapid plasma reagent, was reactive, and they also did a CSF fluid analysis that also showed a high titer in the CSF fluid. So this was technically neurosyphilis. And I'll tell you, when you have syphilis in the eye, it's really by definition, actually, I'll amend that to say when you have it in the retina and optic nerve, it's by definition neurosyphilis, because that is nerve tissue. That is brain tissue. Your retina is brain tissue. Your optic nerve is brain tissue. That's a cranial nerve, folks. So if you have some patients come in, all they have are eye symptoms. All they have is eye involvement. They don't have any evidence elsewhere of any syphilis until they get the blood test, the CSF fluid analysis that shows up. What do you know? Syphilis. And so it is neurosyphilis. And just to give you like a quick rundown of kind of the stages of syphilis, I had to research this. As I brought out my trusty first aid book because we don't think about this in ophthalmology as far as syphilis goes. In terms of the different stages. So we have primary syphilis, which is usually that painless chancre. That's the lesion on your genitals. If you have a lesion on your genitals, like an open wound, abstain from sexual activity. That's all I'm saying. I may be an ophthalmologist, but that's what I would recommend. Maybe don't like have that lesion be in close contact or touching any other part of anybody's body. All right. So it's localized disease though. Primary syphilis. The first thing shows up, localized disease, but also it's a painless. So if you don't like look or clean your member or your genitals very often, or you may miss it, I guess, if it's painless. Then it moves on to secondary syphilis. Now that's disseminated disease, and patients will often start getting a rash. So that's the rash on the palms and soles of the patient's feet. You can get these wart-like white lesions on the genitals, lymphadenopathy. You can get some hair loss. So this is secondary syphilis, and then that can turn into latent syphilis, where the symptoms go away, but you have your positive serology. So your tests would still be positive. Your RPR would still be positive. Then you get tertiary syphilis, which is when it progresses to include more neurologic symptoms. And so like neurosyphilis type of thing. You get the Argyll-Robertson pupil. Everybody, that's like a buzzword we talk about in ophthalmology when we study for step 1. I will say not really clinically useful as an ophthalmologist, because often if that's there, then you see other problems as well. Like that's like probably the most subtle finding that you'll see in someone with neurosyphilis is like Argyll-Robertson people. Now, maybe people have made a diagnosis just based on that, but that would be a tough one. So Argyll-Robertson pupil is when your pupil reacts to accommodation, but it doesn't react to light. And that's just based on the having lesions in a part of your midbrain and your dorsal midbrain that affects a specific nucleus in that specific part of the brain that causes the consensual light reflex to be non-functional. Accommodation. So when you go from focusing on something in the distance to focusing up close, you accommodate. And when you do that, your pupil constricts. That's a different pathway. We're not going to go into detail what those pathways are. Very boring. Not that important. Enough people say in the comments they want to hear all about neuroanatomy of the pupil reactions. Sure, let's do it. But I'll wait for you to tell me to do that before I jump into it. And so, but another thing though is just in general, syphilis is one of these like the great masqueraders, one of these masquerading diseases, especially in ophthalmology, because so many things can be a part of the constellation of signs and symptoms that come with syphilis. So people can have just inflammation. They can have this retinal whitening. They can, which is, by the way, this diagnosis for this patient, the whiteness of the retina, acute syphilitic posterior placoid chorioretinitis. That's the official diagnosis of this. Something that maybe you can find in ICD-10. I don't know. I've never actually had to look that up to put it in the note. So that was the diagnosis, but you can have that retinal whitening. You can have retinal detachments. You can have neuroretinitis. It can develop. You can just have cataract from syphilis. So all these kinds of things. And so, it's why it can be a really difficult diagnosis to come to unless you have obvious sign, like things like the lesions on the rash on the palms and soles of your feet. But what I thought was interesting, the reason I thought about this patient is because I did see a news article that talked about rising syphilis rates. And so I have some data for you on which states have the highest rates of STDs, and which, this data, I think it includes HIV and syphilis here. But the highest concentration, the top three, let's see, how about the top three are Mississippi, Louisiana, followed closely by Alaska and Georgia. They're the only states where the STD rates exceed 1,000 cases per 100,000 residents. The lowest in the whole country, the states with the lowest rates of STDs, maybe you can guess them. New Hampshire, Vermont, and Maine. Now that's interesting. I wonder if it's just because it's like for most of the year, it's so cold that no one wants to take off their clothes and have sex. That was my guess. I don't know. Maybe there's something about Treponema pallidum, which is the organism that results in syphilis. Maybe there's something about like cold weather, warm weather. I don't know. Who knows? Maybe epidemiologists can chime in. But I think it's just because no one wants to take their clothes off because it's like winter 7 months out of the year. And so, but that assumes that there's no heat indoors or that people just enjoy having sex outside. I don't think anybody would do that during winter though. So I think there's a flaw in my reasoning. I don't know. Anyway, positive guess. Like let me know what you think. But that's my patient. That was the patient with syphilis in the eye, neurosyphilis. The patient ended up having a continuous IV penicillin infusion over 24 hours after the diagnosis. And that continued actually for 14 days. So 2 weeks of IV penicillin. Takes quite a bit of penicillin, but what a wonderful medication. It's been around forever and it still treats syphilis really, really well. Patient had a full imaging, everything of the brain. And unfortunately, the brain and spinal cord were uninvolved. And vision improved to about 20/50. So this patient's vision, again, started out, count fingers, really poor vision, improved to 20/50 with treatment, which is awesome. So you can really still get a good outcome from neurosyphilis. So yeah, that's it. That's all I got for Knock Knock Eye. Thank you all for listening. By the way, go check out the YouTube channel at Glaucomfleckens. That's where we post all the video podcast episodes if you'd like to watch me while I talk. Go check that out. We've got some great interviews coming up, lots of different things, lots of different topics. Leave a comment because I do try to every now and then I'll look through the comment section and then address some comments here on the episode. So leave a comment. Let me know what you think. Leave a review. I would appreciate that as well. Any place you listen to the podcast. But that's it for Knock Knock Eye. I'm your host, Dr. Glaucomflecken. Thanks to my executive producers, Aaron Corney, Rob Gilman, and Shanti Briggett. Editor and engineers, Jason Portizo. Our music is by Omer Benzvi. Knock Knock Eye is a human content production. We'll see you next week.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.